There it goes. Oh. There. Now we take a look at what we have remaining here. That's here with good irrigation. Now, we've insulted these gum tissues just a little bit more than ideal. We're going to make sure the socket here, there's no evidence of significant disease in here, which is really good. It means that we don't have to change the biology significantly. But this has had a root canal, and often there's some periapical granulomatous tissue involved. And any fragments of tissue that might be remaining, we just got to clean it all out. So our intent is to actually compress the heating process within this socket so that we can effect a faster and a better quality heating result. Now, things that we would like to prevent, if at all possible, of course, is the movement of these papillae. But in the difficulties of getting this particular tooth out, we find that they have immobilized. So one of our intents is to stabilize all this tissue. One of the most important things we want to accomplish is to make sure that the oral environment does not actually get into that socket to influence it negatively. In other words, we don't want a bacterial colonization on the buccal walls in there to cause a localized osteomyelitis. That's how we lose the facial plate more often than not. We will go to our laser. We're going to go down into the base of the socket, apex of the socket. Make sure that if there is any granulomatous tissue down there, or inflammatory tissues, that we resolve it. We're going to get rid of any soft tissue on the walls of the socket as well. Our intent right now in this socket preservation protocol is to do everything we can to maximize the healing potential. One of them is to get rid of the sulcular epithelium. Max, how you doing? Okay, good. Now this is often done by some clinicians with a burr. And the burr works fine to disrupt the epithelial barrier for healing, but doesn't do an awful lot to remove bacteria, which is often part of the gingival process. So we're going to accomplish both by removing any inflammatory tissue and the sulcular epithelium here to facilitate the proliferation of gingival tissue across the opening. We're going to use platelet-rich fibrin, PRF material, to fill part of this socket here. That's because this is the technique that we happen to find to be the most effective in regenerating the bone tissue in here. These are concentrated platelets taken from our patient's blood. And we're going to take another one. Let's have a 2x2. Okay. Now, for many practitioners who are not drawing blood and concentrating platelets, you can put any number of things into the socket, be it HA-based products or collagen. This is a 5-wall bony socket without an awful lot of infection, so this is actually very predictable. And we have a PRF membrane down at the apex of the socket, which is helpful to get the growth hormones activated. Then we're going to pack this socket with irradiated cancellous bone. This is vertebral bone that is developed for Rocky Mountain Tissue Bank in Denver, Colorado. And it's an excellent product to use. We'll use this in a lot of different areas, including sinus grafts. We can press that in. Let's have a little dab. Thank you. And as you fill these grafts, you just want to make sure it's compacted sufficiently to give a bit of resistance rather than being too free-flowing and they're moving around an awful lot. Part of the graft protocol is to make sure that all the particles of a graft remain fairly stable and immobile. Okay, now we've got that filled pretty close to the crest of the bone. And what we're going to do right now is fill the balance of it up again with platelets. Let's have a dab on that. Good. Oh, I need to compress that in there. Now, these growth factors contained within the platelet-rich fibrin will affect bone, but they'll also affect gingival tissue beautifully as well. So what we have right now is the PRF material almost to the very crest of the gingival tissue, and that works very, very nicely. What we'll do is we're going to do a double membrane technique at this point. This is one of the things that differentiates this protocol from others, and we're going to start with a product from Cetogenics, and that's NeoMem. So we're going to shape a piece of NeoMem here, membrane. It's a semi-rigid collagen membrane. It has barrier qualities, but what I like about this product is it also has some memory. So for situations where people are biting on these areas while they're in healing, which we don't like to see, but we have to do our best to protect the patient against misuse. We cover up that area, and it just has to extend to or a little bit past the gingival complex margins here. And that's our first level of membrane. Now that will be retained within the body, and what we'll do is put a different membrane on top of that, which will be removed. Now this material here is also a product from Cetogenics. It's a non-expanded polytetrafluoroethylene membrane. And so it doesn't have any porosities, and therefore will be part of the full barrier aspect of this. And notice that I'm making it a little bit bigger than the actual socket opening, because I want this to extend past the gingival tissues. and we'll tuck it under. Just like that. So we have 2 barriers now. This one will come out in 2 weeks, this outer barrier. Now that barrier is comprised, the final barrier is comprised of 3 components. One is the non-expanded PTFE membrane, the other are sutures, and we're going to use fluorovicryl sutures for this. You could use pretty much anything you want, but ideally a braided suture is better because it absorbs the 3rd component which we'll be using for this procedure, and that's periacryl from Glue Stitch. So we're going to just give this a bit of a wash right now. We have pretty good isolation at this point, but we're going to give it another level of value. Okay. We're just going to just dry that for a second. In here we have our Glue Stitch product, periacryl. This is the viscous part of periacryl, and it's applied internally here, and we will cause this to set. There's 2 ways. Now when you have a wide open area, it's very good to use your finger. So you can go in there and dab at it, and water sets this material. But my fingers are too big to get in the center there effectively. One of the things you can do is take a gauze. What we're going to do is we're going to fold a 2x2 here in 2 parts. We're going to add it into, we're going to soak it pretty heavily. We're going to take out any significant excess. It's still very moist. And we're going to use our cotton pliers here. Good. Now, our goal is a completely sealed off structure here. And we'll do several applications here. And this actually fuses the gum tissue to the suture material, to the PTFE membrane below. And when you take this out in 2 weeks' time, you'll actually have it all come out as one cohesive product. You pull this. And that's pretty much the process. What we'll do at this point is we'll check for any splash of material that has gotten into the occlusal surfaces or adjacent to structure and remove it. I think we've been relatively clean through here. And everything is sealed off very nicely right through here, interproximally as well, over the center of that. And now, very little will disturb that. So in the course of another 2 weeks, all that tissue will start to regenerate without any mobility, any influence of the pathogens and microorganisms in the mouth. And what will happen with Max here is, in spite of the difficulty taking that tooth out, he'll have absolutely zero discomfort. And that comes from isolation of the socket area from the oral environment. And I think we can call it a day, Max.
Okay.